So I want to welcome everyone to today's Crisis Jam. This is episode 145, and we are delighted today to be highlighting two very good friends, but in addition, very astute individuals, Justin Volpe and Amy Brinkley, who are going to be bringing our topic today of peers across the crisis continuum. We've had numerous discussions about the role of peers in this, so we're thrilled that they are now part of it and are going to be doing a presentation for us a little bit later. I also want to thank our ASL interpreters, as always, for the outstanding job that they do in bringing this message across, and I want to thank each one of you for joining us today. Just remember again that there have been some changes in the talk.crisisnow.com site. You will no longer see a direct link to the Crisis Jam, that because of incidents that did occur before, we're now having everyone register. And we're asking you to please work with us on that, because we're diligently trying to get everyone registered to get our numbers back up again. So just hang in there with us, folks, and we'll be able to make that happen. But just a reminder that that page does exist, and it allows you to be able to go backwards or forward. If you want to see previous episodes, please do so. Just jump on board and you'll see how that works out so well. Next one. We always highlight our top 5, and as you look at the top 5, not a lot of movement, but still there is the focus on looking at the number of episodes that have been seen that focus on youth editions. So as you look at the top 10 or so, you begin to see a theme kind of develop that many of you are really interested in and have been going around looking at varied components of the crisis jams. And just as a reminder that if any of these are intriguing to you and you did not have an opportunity to see it, please go back and you can review any of the prior episodes. We also have had over 400 unique speakers over the 140 some odd episodes that we've had so far. And this is just a reminder to all of you, if you have an idea of something that you think might assist in the crisis jam, please don't hesitate to share that idea. Send Karen an email message or put something into the chat box, and we'll be so happy to respond to that. But as you can see from the listing here, we have had a myriad of speakers over the 140 some episodes of the crisis jam, and all renowned individuals. This next slide reminds us again of the presence of the Hispanic Heritage Month as part of what has been going on heritage-wise. This has been going on since the 15th of September and then goes through October 15th. And there are some links that will be placed in the chat box from the MHTTC network, as well as the mental health and Hispanic community sites, to give you some additional references and some resources as this month is being celebrated, and the degree and level of care that is to be provided to not only Hispanic neighborhoods, but also taking a look at all marginalized and community levels of care. Let's go to the next slide. As we take a look now at the Pew organization that has recently taken a look at, after 1 year, the opportunities and challenges that remain for 988 Suicide and Crisis Lifeline. As we're developing the 988, all of us are aware that there are still issues that we're working with, and the challenges that are highlighted on this particular slide underscore the things we know about. We know about the workforce shortages. We know about the limited language access and the access to ongoing care. And what you've seen in a previous episode is focusing on the limited language access, but this now fills it in and also adds to the theme of what we'll be talking about a little later today by looking at the workforce shortages as well as the access to ongoing care. Next one, please. Reminder about the SAMHSA store, that the materials are still available. Please don't hesitate to go within the site. You can acquire stickers and pads and wallet cards, because we need to get that word out to others. Remember also that there are 6 Spanish options that can be utilized here, and you can receive up to 326 pieces of material absolutely free. Next slide. Also, looking at these fabulous t-shirts, the reminder that these t-shirts are still available with the writings, and we just a reminder to those that one of the captions that are on the t-shirts comes from one of our speakers today. So we're thrilled that she is a part of it and that she has given that input. The other thing is that hats are also available too, and short and long sleeve jerseys are as well available. A reminder that if you are part of the Crisis Hot Seat, you can acquire one of these free of charge, regardless of whether or not you respond to the question correctly or not. And that's a good segue to now get into our Crisis Hot Seat, Trivia Hot Seat for today. And today we have with us Henry Wenger, who is the Chief Technology Officer with Behavioral Health Link. So Henry, do we have you, sir?
Yes, good morning. Sorry I can't join you via video, but I'm here via audio.
That's okay. That's okay. We have you and we have your voice, and that's what we need. So thank you for being on our hot seat for today. And again, as a reminder, the response to this is not necessary to get that free t-shirt. So you are working already from a win-win situation.
Excellent.
So if you are ready, sir, here's the question for today. In October of 2021, Dr. John Draper was the director of the National Suicide Prevention Lifeline. He was asked in the Crisis Jam, what would be the staffing experience and credentialing requirements to answer 988 calls? So the question we raised to you is, what was his answer for the fundamental requirements to facilitate calls, texts, or chats? So the options you have available are A, high school with 4 years experience, B, high school with appropriate training, C, training and competent and caring, or D, master's level or higher. So you have several options here, sir. You can either answer it as you see fit. We are polling the audience. You can wait for that as well, and we'll give you the audience response. And you even have the option to phone a friend if you wish.
Wow, that's excellent. I've been working with John for a little bit now. I think I know how he thinks. So I'm gonna try this one myself.
Okay.
And I'm gonna go with option C.
Very good. Very good. So we have polled the audience, and let's take a look, at least if that's okay with you, and just see how the audience responds.
Excellent.
All righty.
Hi. What are you doing?
Okay, do we have responses? There we go. Thank you so much. And it looks like, Henry, they are on your side.
Excellent.
At least 89% that are agreeing that it is C, trained, competent, and caring. So let's go ahead and see where everyone is. And you are absolutely on target, sir. Trained, competent, and caring. So it's wonderful. Thank you so much. Because this, again, you said you know John Draper. I think one of the things that is so elemental in this is that this goes to what we talked about a little earlier. And, we go to the next slide, please. We go back to the earlier piece where we talked about how SAMHSA has been responding all along. When we take a look at the crisis contact centers, when we take a look at the response patterns, what we do see is a tremendous connection. And this goes back to the Pew slide that we had a little earlier about the importance in the guidelines of looking at the crisis contact centers, the mobile crisis services and stabilization services. But in response to the question, really looking at how trauma informed, I think a lot of those responses have been. So Henry, thank you so much for that, and enjoy your t-shirts. And we look forward to you coming to us at a further time.
My pleasure, Brian. Thank you.
You are so welcome, sir. We're now ready to move into the over-under question for today. So I believe we have Dr. Draper with us, John Draper.
Hello, good to see you, Brian.
There he is. Oh, wonderful seeing you. I tell you, thank you so much for being a part of this. Now, I'm kind of a newbie with the over-under, so just bear with me if I blow.
Me too, Brian, me too.
It's great. But we're looking at this, and I think the highlights here that might be a little helpful is we're focusing on the team behind the crisis calculator. When we're looking at the figures and we're looking at the numbers, we're looking at the crisis calculator. So the team behind the crisis calculator has estimated that nearly 50,000 staff are required for the core crisis workforce nationwide. So the question is, according to the national guidelines, what percentage might be peer roles? So what we're going to ask is, you would just give us a number and then we're going to move forward from there.
All right. And then I guess after I give a number, people get to guess whether it's more or less than what I'm guessing. So I'm going to try my hand at math here for a little bit. I mean, given that one of the two folks that make mobile crisis responses could easily be peers, and most of the folks in crisis stabilization services, they absolutely need some medical personnel. Probably most can be peers. So I'd say at least 50%. So I'm just going to start. I'm going to give you 50%, Brian.
Okay, and that's great. And again, a reminder on the slide, if you don't see, when they say peer roles, it's also a reminder that peer roles by this definition does not require clinical, nursing, or medical credentials. So if that doesn't change anything or does change anything for you, I just wanted to make sure that that piece was there. All righty, and let's move to the next slide. On this next slide, what we want you to see are the things that we've just talked about in terms of the acquisition of the data. Because when you look at the peer staff versus the clinical nursing and medical staffing, you notice that what you see here is that these crisis calls, text, chat hubs, the crisis mobile teams, and the crisis receiving centers have numbers that have been developed through the crisis calculator groupings. And what we're going to be asking is if the audience now, who have all heard you say, John, that it is 50%, we're going to be asking the audience if you feel that it is greater than 50% or under 50%. So if we could go with that poll. Righty? And again, is it going to be over 50%? Or is it going to be under Dr. Draper's 50%? If you'll submit that, please. We can take a look at it. And
Love it.
Here,
Love it.
Again, almost 3/4 of our audience agree with the fact that it is greater. So the answer is, and we'll move to the next slide.
Yes.
Actually, a little
Excellent.
higher. So you were phenomenal, right on target. Absolutely love the way that you processed that and opened it up, because indeed what this does do is it highlights how necessary it is for us to understand that distinction and where peers really fall within those roles and how imperative it is to look at them in those vital functioning capacities. So Dr. Draper, thank you so much.
Thank you, Brian. Great to see you.
Could you just stick with me for just a hot second?
Sure.
Because I wanted you to take a look at this next quote. And I'd love to get your thoughts on this quote. Because when I saw it, I had all sorts of feelings that came behind it. But it comes from Brian Mashara, and he says, selection criteria should include empathy, respect, and the ability to establish a good initial contact.
Oh, absolutely. Brian, that's where it all starts. And it actually ends if you don't have empathy. They don't give you a good assessment. They don't do anything that you think they should do. They don't collaborate with you. It all starts with, do you understand me? Do you hear me? Do you care about me? And that's exactly what must happen with every contact.
Fantastic. And again, it will sound a bit like a broken record, but everything that you just mentioned really goes down that theme of SAMHSA's really adherence to the trauma-informed care principles of just having that empathy, being able to listen, being able to kind of process things as they are going through. So again, John, thank you so much.
Always a pleasure, Brian.
Both components. Take care, sir. And again, I love the quotes that are placed in there. Empathy is where it starts and where it ends. Perfect. Thank you so much. And I think now we are ready for our feature presentation. So we have today two absolutely outstanding individuals that are going to be presenting for us today. We have Amy Brinkley, and Amy Brinkley is our Recovery Support Systems Coordinator at NASMHPD. And we have Justin Volpe, our Peer Support Coordinator at NASMHPD. So again, two highly profiled individuals who have done so much work in the peer realms, and I'm going to in a non-chauvinistic sounding sense, I'm going to turn it over to Amy, and you then, Amy, can kind of process it and continue as the two of you have designed to do. So thank you again for the presentation, and go ahead.
Thank you, Dr. Sims, but I'm going to pass it to Justin.
Hey guys, good morning, good afternoon. It's nice to see everybody. My name is Justin Volpe. I'm a peer support coordinator at NASMHPD. I've worked as a peer specialist for 15 years, since 2008. I'm a person in long-time recovery from serious mental health and substance use disorders. I've been in the crisis system for an early part of my life through jails, rehabs, and stabilization units. And, I worked for most of my life before my role at NASMHPD the last year and a half at a Miami-Dade County jail diversion program. And there I worked with people that got out of jail with serious mental health and co-occurring issues out of jail and into treatment in the community, whether it be housing or whatever the assessment may be. And my role is to provide support with them. And, in my experience, there wasn't a lot for people, and people are ending up in jail. And I think this paper is meaningful that Amy and I worked on, and we worked on together with a lot of our experience. I gotta say, there needs to be more opportunities and peers at different, angles and avenues in the crisis system, and just different levels of care that people may not receive, that may not exist right now. And, I've been doing this a long time, and people aren't happy with the system. So we're hoping this paper sheds some light and brings a different angle to that. So Amy, I want to pass it to you on that note.
Thank you, Justin. Good afternoon, everybody. I think I speak for both of us when I say we're excited to be here on Crisis Jam with you guys, and to be talking about this topic and to share the paper with you guys. I wanted to start by sharing a little bit of my background. So as a lot of folks I think on the call already know, I am a person in long-term mental health and substance use recovery, 14 years by the grace of God. And I have a lot of direct lived experience with the crisis system as well, as Justin does. And I actually lost 3 brothers to suicide and my mother to an overdose. And the most recent loss to suicide was 2 years ago with one of my younger brothers. So definitely have a lot of lived experience engaging with the crisis service delivery system. But I really wanted to kind of jump in and celebrate a little bit, because this is National Recovery Month. And so one of the things that I'm actually really excited about is last week, SAMHSA had a big press release announcement on the new National Survey on Drug Use and Health report that highlighted recovery data for the first time. And anybody who knows me knows I get excited about data, which wasn't always the case, but I'm very excited about recovery specific data. And so I wanted to share some of the stats with you. So 70 million adults aged 18 or over perceive that they have ever had a substance use or mental health problem. Of the 70 million, 29 million perceived that they had a substance use problem specifically. Of the 29 million, 20.9 million, or 72%, self-identified as being in recovery from their substance use problem. On the mental health side, there were 58.7 million people who perceived they ever had a mental health problem. And of those folks, 66.5% perceived that they were in recovery from their mental health problem. So I wanted to just highlight that in honor of Recovery Month, that we are starting to monitor and measure recovery and celebrate the fact that this is National Recovery Month, and note the fact that millions and millions of people on both the mental health and substance use side are identifying in recovery. So if we could go back really quick, I'll be really brief on this slide. Our paper is actually separated into 8 different sections. And so in the opening section, we kind of set the stage. The Biden Unity Address, last year announced a call out for a national peer certification. So we kind of set the stage in terms of the crisis infrastructure and where the peer support movement is. We talk about the national perspective on peers across the crisis continuum. We unpack the peer support history and evolution, because we recognize that that's very important. And then we go into current utilization and talk about data, which we'll get into. And we talk about co-responder models and funding for peer services, and then we close out. So all of that is in the paper. And now we can go to the next slide, and I will pass it to Justin.
So, you know, we define what peer specialists are in the paper and what their roles can be, and where we have seen people in the crisis system, and what, you know, what their role has to be. And, you know, it should be a mutual relationship. And that can sometimes be difficult when people are in unstable situations. But we need to keep that, you know, relationship of what peers are supposed to do and find the right places for them, and to have good boundaries and expectations of employers of what their role is, and to have them have meaningful work. I think, you know, if expectations are brought out right and people know what they're supposed to do and they're not thrown in situations, it could be beneficial for everyone, especially the people served. Next slide to you, Amy.
We can,
Oh,
I thought
sorry,
this was going
this
to be
one's
you,
mine.
Justin.
Oh, here we go. I need my coffee, sorry. So yeah, you know, maintaining those peer support values in crisis service settings can be challenging. And you know, when we started to write this paper, we started to listen to everybody. And in our role with the Division of Recovery Support Services, DRSS, part of NASMHPD, we listen to people and we hear what our stakeholders have to say. And not, like I was saying in my opening, not everybody's happy with the crisis system and believe peers should be doing different things, maybe not in crisis systems at all. And we highlight that in the paper, and those concerns with coercion and involuntary hospitalization. But, you know, in my experience, so we're trying to, you know, take everybody's view and understand and appreciate, which I do. In my experience working in the Miami-Dade County Jail Diversion Program, people are just ending up incarcerated across this country with serious mental health issues, and they're not getting any help. So, you know, in my lens, I think people with lived experience, even not necessarily peer specialists, need to be involved in this process to advocate for people, to keep them out of incarceration and help them get different levels of care in the community. And there's a lot of things that, you know, are not factors in the crisis system, like housing. You know, if people don't have safe, stable places to live, you know, how are they going to get the treatment moving forward, or have their choice to do what they want and not end up in some of these predicaments?
Thank you, Justin. So, yeah, we can go to the next slide. So I'm going to try to go through the next few slides rather quickly for the sake of time. And I just want to underscore that our 15-minute presentation is not going to do this paper justice. So we encourage everybody to go read the paper. So one of the things that we highlighted in the paper was the peer support, the SAMHSA advisory document on peer support services across the crisis continuum. And one of the things that we highlight in the paper is the key considerations for peer support workers working in crisis services to consider, for the entire staff to consider as it relates to the peer's role. So next slide. So towards the center of the paper, one of the things that we really highlighted and wanted to unpack was data. So we wanted to understand where peers are being employed within the crisis service space. So when Justin and I started at NASMHPD last year, we worked with NRI to get some additional peer-specific questions added to the state profiles. And so this past year, NRI put out some really great reports on peer support, of which we were able to pull some of the numbers. So what we found from the NRI workforce report is that 17 states reported shortages of peer workers within call centers, 24 states reported shortages of peers within mobile crisis teams, 23 states reported shortages of peers within crisis stabilization, and 18 states reported shortages within crisis residential. Of the 44 states that responded, 75% indicated that they were actively recruiting peer support workers. You can go to the next slide. What these numbers did not necessarily tell us was how many states were actually employing peers within those spaces. So it showed the shortage, but not necessarily, still didn't fully tell the story, because we have no idea how many states are actually employing peers in those settings at all. So what we did is we came up with an idea to send a survey out to the Division of Recovery Support Services that Justin mentioned, to get feedback from the recovery leads on whether peers are actually being employed in these settings. And so how we identified the settings is we took the SAMHSA crisis advisory document that listed out the continuum of the crisis continuum and settings where peers are employed, and we used that to document within the survey to get feedback on. So you can go to the next slide, and I'll just briefly cover a couple examples of where states responded. So 17 states responded. We didn't give them much time. It wasn't a pre-planned thing. It was kind of a pretty rushed thing. Honestly, we need to get better at better data for sure. We already know that, and that's highlighted in the paper. But what we saw is that 14 of the 17 states reportedly had peers working in warm lines. 14 states were using peers in crisis planning, and so on and so on. And all of this is unpacked in the paper. So next slide, please. Sorry, guys, I know it's kind of rushed. We've got a lot to cover. So Medicaid is, so what we also use the NRI state profile report to highlight in the paper is the average Medicaid rate. And we also highlighted from the NRI state profile reports how states are advocating for increased Medicaid rates. What we weren't really able to accomplish, and we're hoping to at some point in the future, is identify what the Medicaid rates could or should be within crisis services, because we recognize that those spaces are going to be more stressful for the peer. So we should take that into consideration in terms of not only Medicaid reimbursement rates, but also salaries. If it's highly stressful to work in this environment, we need to be compensating peers as well as the rest of the behavioral health workforce appropriately for that. Next slide. And this is you, Justin.
Yeah, well, we see a need that, we were talking about in previous slides, whether the numbers were completely accurate or not, where we need to increase the workforce, the peer workforce. And in doing so, we need to enhance the response to different communities. If we're going to get people to trust the system that's thrown them overboard, how are we going to do that with the same way we've been doing things for years? And we need to come up with different responses to people of color in different communities that don't trust the system. And you can understand why when people are ending up, misdiagnosed, incarcerated, and we highlight the police response to Black communities is not good. I work here in Miami-Dade County with CIT officers, and CIT is really big here. We have 8,500 officers trained to provide that care. And but even the International Chief of Police Association, and I know I messed that up, says in a statement that if somebody is having a serious mental health diagnosis and it's a mental health call, that it should be in a mental health care professional, not the police. Next slide. So we have a workforce shortage, right? We know we need to serve different populations. We need that, and this is including not everybody, veterans, LGBTQI, different populations, immigrant populations, juvenile justice, criminal justice systems, right? But we have a workforce shortage. So how are we going to get all these people when we're already serving this population? And for that, we need training. We need to better prepare the workforce to serve different populations and to be culturally competent and to understand the communities they're serving in the meantime. And with that, we're almost out of time. I'm going to pass it to you, Amy, so we can close up.
Thank you, Justin. So two things that we did is we highlighted some of the, it looks like that slide got taken out. Okay, so I'll just pivot real quick. So in talking with stakeholders across the country, what we were hearing reflected back to us was a desire to learn about alternative responses, alternative to co-responder responses. So what we did is we went back to the drawing board. We actually ended up taking out a couple state examples of crisis services being implemented in some states. And instead, we tried to list out some examples of alternatives to co-responder models. And a lot of that work was prefaced by the fact that a lot of communities of color have been historically traumatized by the system and first responses. So one of the mental health things that are noted in the paper is a mental health response to a mental health crisis. And so what we wanted to do is identify alternatives to co-responder models, not as in saying that it's bad. In fact, we highlight in the paper that there's no research saying that one or the other is better. And so there's really just no research. So each community needs to determine for itself what's the best response. And so what we did is we highlighted in the paper examples of both. And so that's actually reflected in the paper. And then you can go to the last slide. We put a summary of the recommendations that we came up with, and we are still working on finalizing those. So, and I think we're at time.
Yeah, I just want to say it was a pleasure, and we really thank, NASMHPD for being employed and having this role and having the opportunity to write this paper.
Amy, Justin, as always, you've heard me say this almost like a broken record. Thank you so much. That was a lot of information to absorb in a small amount of time. And Amy, I have to reiterate your point. It would be extremely fruitful to gather that particular article and read it over in detail. There were a lot of wonderful comments placed in the chat box that you're welcome to take a look at that really stress the importance of this information being disseminated in a wider span, so that individuals have the opportunity now to really understand better the role that you guys have been playing. So thank you so much again. We're going to move to the roundtable discussion at this point. And again, keeping it in the NASMHPD family, we're going to start with Jenna Schofield, who is our Senior TA and Communications Associate here at NASMHPD. And Jenna, some comments, please.
Sure. Hey, Dr. Sims. Hey, Justin and Amy. Nice job with this presentation. And thank you guys for asking me to share a few words with you here. So I was involved, somewhat tangentially, but involved in the process of writing and editing this paper with Amy and Justin, Dr. Pinels. And so really, I just want to acknowledge the massive amount of work that they have put into this. I mean, Amy alluded to the fact that this is very much a high-level overview and folks should go and read this paper. They absolutely should. They really put their heart and soul into it. They've done such a great job, I think, of incorporating their lived experience lens, their expertise in state service systems, and really in their roles at NASMHPD, Amy and Justin interact with recovery support leaders, other state mental health agency leaders from all over the country every day. And every day they're hearing about the successes and challenges with respect to peer work and also with respect to implementing crisis services. So they're really uniquely positioned. I think they're privy to that 50,000 foot view of what is going on in the peer space across the entire country. But they've also done the work on the ground themselves, and they bring their own lived expertise perspective as well. And so with that wealth of experience, it just got poured right into this paper. And I think they did a really nice job in particular of demonstrating how peer services and person-centered clinical treatment really complement one another, and how they can work really nicely in harmony to improve services for the individual in crisis. And I also just want to really thank SAMHSA here for supporting this paper. I think everyone here recognizes the massive value that peers bring. And now we've had this real boom in crisis services associated with 988 over the past couple of years. So there's tons of interest in incorporating peers into crisis services spaces more effectively. But I think we really needed more of this concrete guidance on exactly how to do it. And that's what Amy and Justin have worked on here. So thank you, SAMHSA, for recognizing the need for this paper and supporting it. And as well as supporting the other papers. This isn't a one paper in a series of 10 that we've worked on this year. I think Dr. Pinels is gonna talk about them a little more coming up in the NASMHPD update. That's it from me. I don't know, Dr. Sims, if you want to hand it over to Ava for her thoughts.
Before I even do that, thank you, Jenna, for what you are doing and everything that you did to help make this a successful portion as well, because it's been a team effort. And again, getting this word out has been so critical. So thank you. So I will now turn it over to Ava Kaufman, and Ava is our senior program specialist here at NASMHPD. And Ava, some comments from you.
Thanks, Brian. Hi, everyone. Yep. So my name's Ava, and I'm on the TTI team specifically at NASMHPD. So Justin and I work with a small award that goes to states, and Amy is sort of in the larger coordination space for that. But I mean, as you all know, I'm sure Amy and Justin have been such invaluable additions to the NASMHPD team. I obviously speak from the TTI perspective. Having Justin on every single call with those states has ensured that almost no award or project goes without peer or lived experience involvement. And it's easy to talk about, and it's easy to say your application has to involve peers, but having Justin on that call who can actually give concrete advice on how to incorporate them, how to more fairly compensate them, brainstorming ways to leverage funding for them, all of that has just been so valuable. And I wanted to, of course, thank Amy and Justin for, of course, being vulnerable and sharing their experiences. I think sometimes we take for granted that peers and people with lived experience talk about their own lives, and that's just not easy. And many people don't have to do it. So thank you guys for sharing. And I do have a quick question for the speakers. Just a bit of background. I used to work in a more clinical setting at an eating disorder treatment center. And it followed a pretty traditional structure, of having dietitians, therapists, doctors, nurses. But I was acutely aware of the lack of lived experience roles that were there. There was a pretty big divide, of course, between the clinical care team and the patients. And I'm sure, something you hear a lot in the clinical world is well, why would I let you help me? You don't know what I'm going through. You don't know what I've been through. And so that's an area where I could have seen that a peer or at least staff with openly lived experience would have been super valuable. And I'm just wondering if you guys could think of any concrete scenarios where there's a big gap, and of course we know that every part of the field could use more peers and needs lived experience. But I was just wondering if you guys have any specific examples where you've seen that peer or lived experience involvement would have made a tremendous difference.
Yeah, I just want to thank you, Ava, and thank you, Jenna. I don't know if you guys can hear me. Hopefully you can. Oh, there I am.
Yeah, we can.
I want to highlight something that Sonia Burns said in the chat, which is very accurate. And I'm going to go back up and read it because, people with IDD and developmental disorders are ending up incarcerated in crisis systems and without proper care. And there needs to be more information on that. We need to talk more about that. I think, Ava, we've dealt with some initiatives with the TTI that has kind of looked at this population from a different perspective, but I think it's just starting. And, at least from my experience, in the criminal justice system, everybody came through. Was I trained properly to deal with them? No. I treated everybody humanely, respectfully, right, the way we should. But there needs to be more. There needs to be not only more peers with this experience to do this work, but appropriate levels of care so people aren't ending up in long-time crisis facilities, incarceration, and basically homeless on the street, if not. So thank you. Back to you, Dr. Sims.
Oh, thank you. And thank you all. One of the things I did want to share before we move to the next segment is how eminently accessible both Justin and Amy are, or all of the team at NASMHPD. So if you have any questions that you may not have posted in the chat box, please feel free to reach out to them. They are wonderful about responding and can give you a wealth of information from how their connections with SAMHSA and all of the wonderful work that SAMHSA has been supporting to be able to get questions addressed with regards to maybe some of the challenges that you might be seeing in the peer network. So thank you all again. Excellent, excellent, excellent. And I want to move now to our SAMHSA update. And we have James Wright with us today. He's the Division Director with Crisis Operations out of SAMHSA. So go ahead, James.
Hey, thanks, Brian. I'll be quick. So we're super excited today to be able to announce the awards of the next year's 988 funding. So if you go to samhsa.gov/grants, you will see the fiscal year 2023 awards. We awarded 53 grants to states and territories for 988 response. That's for states, for both states and territories. We awarded 20 grants for the 988 tribal response. Many of those tribes are new to 988, so we're excited about that expansion. And we were able to continue the Crisis Center follow-up grant program under the 988 office. So that is exciting, and that program specifically expanded quite a bit from $360,000 in 2020 to just at $5 million in 2023. So all of those are out, and so they start their activities here in about 2 days. So we're excited. Happy to answer any questions, Brian, but that's the main update from us at SAMHSA.
I certainly want to come back and thank you. Thanks, SAMHSA, for the leadership, the guidance, the vision, and just where this is going, because it's such a critical need, and you guys have been on point. But thank you for, again, the grants per se, being out there, and a reminder to the states to really take a good look at that TTI portion there. So thank you again. We are now ready to move over to our NASHPD updates, and we have with us today Dr. Deb Pinals. And Dr. Pinals, if you are here.
I'm here.
There you are. Wonderful. So go right ahead, Dr. Pinals.
All right, well, we can go to the next slide. So you already heard from Jenna and others, and Amy and Justin, of course, about the paper on peers. I'm here to take just a bit of a step backwards to talk about our series this year, which is called Connected and Strong Strategies for Accessible and Effective Crisis and Mental Health Services. We're very excited about this series, and we really want to thank SAMHSA for supporting the work, and to all the amazing authors who helped contribute to the work. And of course, I have to thank Jenna Schofield, who's been my lead partner on this project. There will be 10 papers, and I want to talk about the first one that really brings out the theme that we were working on in this connected and strong approach. Just to remind people that this is part of our Beyond Bed series. We've been producing at NASHPD technical assistance papers for many, many years. This series goes back to 2017, where we really spoke about the importance of the continuum of care, and that has shifted over time to really focusing on crisis services. And so this is a series. You can get it on the NASHPD website. You can get them through SAMHSA. Each year there's been 10 papers that have highlighted certain themes. And so I would encourage you to look at those resources or reach out to us at any time, and we can help point you in the right direction to find them. For this year, we really were focused on, for the Connected and Strong theme paper, President Biden's unity agenda that really calls for bipartisan support around strengthening system capacity, connecting Americans to care, and creating healthy environments. And within that, President Biden called for many different aspects of behavioral health supports, including workforce with the peer work, as you heard about, building out 988 in the crisis continuum, building in serious mental illness and substance use disorder treatment integration, making sure that people have access to care, that telehealth is accessible and improved, and that there are healthy environments, especially for our youth. And there's many, many initiatives, as you all know, that are taking place at the federal level. We just heard about new grants from SAMHSA, HRSA, all the federal agencies are diving into many of these different kind of activities under the president's call for action around the unity agenda. Next slide. And, you know, as Jenna and I wrote the theme paper this year, we really were looking at what were we hearing from people. We talked to commissioners across the country, you know, on a regular basis through NASHPD. And really, you know, the themes were clear. The workforce is in crisis. We can do a better job of matching level of need with the level of care. We have to retool ourselves as the public health emergency ended. There's challenges and opportunities with the current fiscal climate. We know that opioids and substances are still devastating our communities, as is suicide. And we need to really reimagine the intersection of mental health and justice at the law enforcement and crisis level and at other places, looking at social determinants of health and really paying attention to our youth. Next slide. So with these themes, we developed what we really think is a call to action around unifying principles, again, under this connected and strong theme, that really what we're hoping over this year is that people will continue to engage multiple perspectives. That's not just multidisciplinary perspectives, but the perspectives of people that don't fall under, quote, disciplines, that we really are looking at the perspectives of many voices to try and engage the population and build out services that we really want through mental health leadership and behavioral health leadership and advocates to strengthen and connect everybody to social services, to really foster social connection in light of the Surgeon General's report and recognition that social isolation is one of the leading contributors to emotional challenges. Really looking again at from a trauma perspective of addressing and preventing trauma, and then fostering engagement, which means not just making care accessible, but making care something that people want to stick with and not drop out of. And so really thinking about, again, what does engagement look like across all populations? And I see people in the chat also talking about family and natural supports, and absolutely that's the multiple perspectives we need. So these were the themes in the Connected and Strong, what we call the umbrella paper that leads the series of 10 papers. And when it is produced, which it'll be soon, hopefully it'll be available publicly. There's I think the recording of the NASHPD presentation on it is available already on the website, and you'll be able to dive into each of these and sort of see more of the background for them. Next slide. And then, as we'll promote and highlight across many crisis jams to come, the other papers you heard today about the peer support paper, which was great. Thank you, Amy and Justin. There's a paper on workforce, medical approaches to mental health and substance use and crisis encounters, innovative uses of technology, 988 and 911 interoperability, facilitating rapid access to care, increasing equitable access to care for people with co-occurring mental health and substance use disorders, intersectionality between faith, mental health, and community partnerships. And last but not least is a paper on long COVID and vulnerable populations. So we like to really get the word out about these papers. We like people to read them and give us feedback. We're already working on the 2024 series. Again, really want to thank SAMHSA, especially Belina Shaw and Dr. Anita Everett, who are helpful, incredibly helpful in helping shape the themes of the papers, Dr. Brian Hepburn at NASHPD and others on the staff who really supported the work. And I think that's it for my presentation.
Well, Dr. Finals, as always, thank you so much for the incredible work that you're doing in this realm. I don't know how you do it, but you have so many different hats, but you do them all exquisitely well. Thank you for this work in here. And I do want to point out, Dr. Finals, when you mentioned about the articles and how important it is to link, there is a link placed in the box that you can sign up for our newsletter, because many of these papers will be published in the newsletter, so you'll have the ability to be able to acquire them, because you do need to link up with them and really gather that invaluable information. So thank you
so much, Dr. Sims.
And thank you. All right, as we go towards the federal updates as well as the state updates, just a little bit of a more so of an update that these are yet to come. Because we're all kind of waiting. These are vital pieces of this crisis jam, and we're waiting for that information to be coming that gives us more of an update with regards to such issues as government shutdown or otherwise, and certainly looking at across the continuums in the states, the data that is progressing towards giving us more information. So you'll see some links posted in the chat box that'll give you further information. We ask that you check on those particular sites, and we look forward to their return to a future crisis jam. So we're now going to move into the crisis talk for today, and Stephanie Hepburn, if she's available. We welcome you into the Crisis Talk. And
thanks, Dr. Sims.
please
So
say.
I'd like to welcome Dr. Kenneth Thompson. He's the Executive Director at Visible Hands Collaborative in Pittsburgh. Dr. Thompson, you shared that peer support is the foundation of recovery. Can you talk about that?
Well, good morning, or I guess afternoon, everybody, depending on where you are. Thank you, Dr. Sims and Stephanie, for this opportunity to talk just a little bit about this. Peer support and recovery, I think, are just fundamentally linked. There really is no sense of recovery unless there is the possibility that somebody becomes a peer supporter. And initially, long time ago, when we first started to talk about the concept of recovery and peers, I don't know that we realized how interlinked they were, but it's pretty obvious that in order for people to be peers, there also has to be a process of recovery. And the fact that there are peers means that there is a process of recovery that people are enabled and engaged in pursuing. So when we had, when initially we started to introduce the idea of a peer workforce into the world of mental health, which you had hoped would be a little bit more flexible, it was a little bit stodgy and a little stuck, and had trouble recognizing that peers could bring something meaningful. And who are these peers anyhow? I think now, looking back on it, that peer support is probably the best acknowledgement that even though we do a lot of things wrong, sometimes we do things right to help people in their process of recovery. And the fact that people, and what else would we have expected, if people start to recover, if they start to find a place and a meaning in life that they want to pursue, how can we not imagine that some of them wouldn't want to pay back or wouldn't want to be engaged in the process that they themselves had just gone through to reorient and rearrange their lives? So the peer support movement and the idea of recovery, to me, are just inextricably linked, and you really can't have one without the other.
You talked to me about hope, and with your own personal experience, how that shifted your lens. You don't have to go into detail, obviously, but if you could talk a little bit about how that made you feel and what that changed within you.
So when I was younger, a member of my family had a significant psychiatric challenge. And it was a challenge that oftentimes people do not recover from, at least historically. At least that's what we were told. And as a psychiatrist, I had learned that lesson. So I was in a point of great discouragement and distress about the situation. I had the opportunity to meet a young woman who was in recovery from this condition. She came and gave a talk to the family members and to our family member about her process of recovery. And it was singly the most important emotional experience I've ever had. And I'm sorry, I didn't think I'd get choked up talking about it, but I really saw an opportunity for possibility. And I think the member of my family also did, because it was there in the flesh. There was somebody who was making a life and had gotten beyond the challenges that they had faced. That's really meaningful. That's hope in a very concrete way. It's the same thing that I saw many years ago when I started at Recovery Innovations, and I went to spend some time in the recovery center in Phoenix, and was there when a guy was brought in, really distressed, in handcuffs by police, disheveled, obviously had been in a very bad place and remained there. And one of the peer workers walked up to him and said, listen, I just want to let you know that this is going to get better. I've been where you've been, and I know that we can find a path out. And this guy, who was, stressed and strained, I could see the change in how he felt at that moment. And I've seen that over and over again in communications between people with lived experience, talking with other folks, sharing the feeling. It's not just the knowledge, but it's the feeling, it's the understanding, it's the connection that is extraordinarily important to being making hope visible.
Thank you so much for hopping on with me. I'll pass it back to you, Dr. Sims.
Thank you. And thank you, Stephanie, and Dr. Thompson. Thank you so much. Very powerful. Check as always, check the chat box. There are some comments in there as well. Very supportive, sir, but thank you. We are now ready to move to our daily feature. Vic, it's been a while, man. But
it has been a while.
Welcome, welcome, welcome. Please go right ahead, sir.
Thank you so much, Dr. Sims. Perhaps I'm influenced by my social worker brain, but I believe the way that we make sense of the world, the way we define ourselves, is a combination of two things: our disposition and our life experiences. And by disposition, I'm referring to the innate qualities and characteristics that influence our personalities. Some of us are natural introverts, whereas others are extroverts. Some of us are risk takers, while others are much more reserved. We're born with it, and it helps to shape how we navigate the world around us. Life experience, on the other hand, refers to those things that we are taught, those things we live, those things we consistently hear, and the things we are socialized to believe, including beliefs and norms may be passed on from generation to generation. And this lived experience helps to shape the way that we navigate the world. It helps to shape our narrative. We live by that narrative. It's where we frame things, where we make sense of the world. And the combination of disposition and lived experience helps us define our community. Community can be defined in several ways. You may define your community geographically, by the town or neighborhood where you reside. But more likely, you define your community based upon relationship. You define your community based upon where you find commonality, socially, racially, culturally, even professionally. And remember that in times of uncertainty, in times of crisis, when we feel broken, when we are afraid, when we feel alone and vulnerable, what we seek most is safety. We seek connection. We seek community. Like many of us, I've often referred to our collective organizations and services as the mental health community, or even the crisis services community. The extent to which we are successful at creating a sense of community for individuals we serve may very well determine whether or not they reach out for help during their time of crisis. And the best way to create that sense of community is to incorporate lived experience into our crisis workforce and to rely upon that expertise in developing our interventions. Our interventions can't be designed to accommodate our reimbursement structure, our political leanings, or our workflow, but must be built to provide hope and healing to those in crisis. We create that sense of community by demonstrating a shared sense of consciousness with those we serve. What happens to you impacts me. We create that sense of community by creating a shared emotional identification with those we serve, a feeling of belonging. We create that sense of community by creating common ends with those we serve, an understanding of and respect for the language, culture, customs, and lived experience of those within the community. If we don't see the traits of a community in the systems we have created, or more importantly, if those in need of healing don't see the traits of a community, we need not refer to ourselves as a community. That would make us, at best, a loosely affiliated continuum of resources. And that is Strong Talk.
Wow. Thank you, Vic. So powerful, but particularly with that emphasis on the connection and the collaboration and the sharing is such a centralized theme of where we are. I do want to remind folks that the link to Victor's podcast is placed in the chat room. Please refer to it. And Victor, thank you as always for being a part of this Crisis Jam. Now, as we kind of close things out, I just want to remind people of the Crisis Jam Showcase that's coming up on October 11th. And during that time, there will be a number of, a couple of speakers, Kevin Curtis, as well as Rachel Lazinski, that will be speaking on just taking a look at the services and provision out of the great state of Utah. So we ask you to keep that piece in mind and work through that. And also on the Crisis Jam debate, really want to focus on this. It's coming up October 18th. It's going to feature two great, wonderful people. Leah Harris is going to take in the debate against the future of crisis care as far as AI, and David is going to cover the for. So everyone, please connect, be a part of that, and we will connect and see just how that's going to be there. So thank you again for watching and being a part of this Crisis Jam, and we look forward to seeing you all back here on site next week. So have a wonderful day, everyone.